Say. بسم الله الرحمن الرحيم وبه نستعين والصلاة والسلام على أشرف المرسلين سيدنا وحبيبنا ونبينا محمد. We are going to continue breast ultrasound technique and image optimizations. And last time we start talking about how to do breast ultrasound. We discussed already the acquisition of high resolution image and the selections of proper equipment. And we said that we require to have near field high resolution probe. We need to have good spatial resolution, both axial and lateral resolutions, as well as the system, ultrasound system also have a good contrast resolutions. And we went through recent advances in technology regarding ultrasound breast. We are going to continue talking today about optimization of patient positioning, ultrasound technique and technical considerations to optimize ultrasound breast and the criteria for image quality, as well as image labeling of breast images. Okay. What is the preparation for patient preparation for breast ultrasound? Are you with me?
Yes. أيوة معك يا دكتورة رباب. First, okay, we should try to ask the patient about the history. If she is complaining of a lump, try to palpate this lump before the ultrasound. And also we have to explain the purpose of the examination and what will happen to the patient. Then the good exposure to tell her to take out her clothes and to lie down with her hands behind her head.
Okay, okay, but my question is specifically like for ultrasound of the abdomen. We ask the patient before coming to us to fast. Any preparation for breast ultrasound? All your information are correct, but exactly any preparations you have to do it or to make it for the patient before coming for breast ultrasound?
No, I don't think so.
Excellent, well done. No special preparation for breast ultrasound, can be done at any time. Okay. What is your impression about this lesion?
Ultrasound of the right breast showing large mixed echogenicity of heterogeneous echogenicity of the lesion with micro lobulation and irregular margin with some.
Where are the micro lobulation here?
Multiple lobulations.
And large. This is one lobule, and this is another, maybe 3 lobules, 3 large lobules. Here it's, yeah. What is your impression about these lesions? Since you have seen it, what could it be?
This
Cancer
large
or
lesion.
fibroadenoma? Is it a cancer or fibroadenoma?
For me, it is not a fibroadenoma.
Why?
I give it by Rad4B because of there is a area of right side of the margin is irregular or indistinct or not apparent like sharp demarcation of the margin. So suspicious margin as this side.
So I expect from you to ask me for more
They-
images. Yes.
More images and history of the patient.
Before to decide, I ask you, is it a fibroadenoma or cancer? Definitely from static image. Last time we said from static image to single image is difficult to decide. Yes?
Yes.
Yeah, excellent that you mentioned these lesions. Some, the microlobulation are very subtle here.
Yes.
But when we sweep throughout or over the lesions, look for the margins are indistinct and microlobulated or not sharp. So that is why full margin evaluation with real-time assessment recommended, particularly for indeterminate lesions. Okay. That is why would like together discussing how to do breast ultrasound and how to optimize the images, going through patient positioning, scanning technique, technical consideration to reach image optimization. Okay. As you know, the breast is a pendulous structure, is a mobile structure. And early on in techniques, okay, on mammography course, we discussed the breast is fixed on the medial and superior part and mobile on the lateral and inferior part, and we discussed how we could manage this while doing mammography. Today, we want to know what is the impact of this in ultrasound examinations. Definitely, ultrasound examination is a real-time dynamic nature, and the patient is moving, and so the breast, since it is pendulous, is also going to be moved during the scanning. And this definitely will affect the examinations and the image quality. And the patient optimization of patient position is essential. Why it is essential? Okay, we need to put the breast in a positions that can be compressed, thinned and thinned out, okay, to avoid artifacts and pseudo lesions. And also sometimes when the breast is moving, can be fall on the transducer, and this can hinder part of the breast not to be examined, and it will affect the image quality. So by optimizing the patient position, we can result in a high quality reproducible image, okay? And this can occur and change the patient position many times during the study. Can you see the difference between this image? This is the same image repeated after this one, and this also repeated after this one. Look here, okay, shadowing, obscuring part of the breast. Most of this image, most of this part of the breast had been obscured by artifact, and the factors, if you look for the focal zone, it is the same, and all parameters were the same. The only difference, it was the patient position, okay? When we optimize the patient position, the image clarified and become a good quality image in both, okay, examples for the same patients, okay? So inadequate positioning may cause portion of the breast to become inaccessible, as in this example, okay? So generally, for ultrasound breast, the patient is lying in a supine position with ipsilateral arm fixed over the patient head as seen in the photograph here, and the shoulder elevated, the side being scanned, okay? You can raise the shoulder with a towel or sheet, okay? And this will help to stabilize the breast. The relaxation and fixation of the ipsilateral arm behind the head will stretch and tighten the breast and make it thinner and prevent its movement, and then also improve the angle of the transducer. This illustration for a patient with the arm at side. When elevated above the head, look for the breast, how it become thinner and tight. So optimize positioning should result in maximum flattening of the breast portion being examined, okay? So that the area being evaluated is thin as much as possible. And the positioning or the degree of obliquity of the patients, okay, it depends on the breast size and how the breast is pendulous, as well as the location of the lesion, okay? If the breast is small, okay, so having little tissue, it will glide over the chest wall. You can examine the patient in a supine position. Or if the lesion in the medial breast, you see, this is the fixed part, so also you can examine the patient in a supine position. For the lateral lesion and for the axilla, you need to examine the patient in contralateral oblique positions, okay? Ipsilateral, contralateral oblique position for the ipsilateral breast. But if the breast is pendulous, okay, or huge breast, then you might need to put the patient in the lateral decubitus to evaluate for the lateral located lesions, okay? And breast lifted up sometimes for the inferior lesion with a large breast in a patient supine, you might need to lift breast and to ask the patient to lift her breast by the contralateral hand up to see inferiorly located lesions. And if the patients could feel a bulbable abnormality only in erect position, you might scan the patient once in the upright position, okay? But remember that the breast in the erect position, the breast, it will be thick and the posterior portion will be difficult to be evaluated. So you need to let her lie down again and re-scan her. But while scanning her in the supine position, if you could not palpate the lesions and the patient could not palpate it, ask her to sit upright and to scan her. And in all situations, the hand or the shoulder should be, for the ipsilateral side of examination, it should be relaxed and fixed behind the head. And sometimes remember that, you see, if there are physical limitations, you might need to scan the patient in a wheelchair or in a stretcher, okay? Look here for the pendulous breast. Examine the patient in a lateral decubitus position. Okay. This is same. Look for the patients. Look for the focal zone. It is the same. Okay. In this, the focal zone, the focal zone. The focal zone, all parameters are the same. The only difference is what is the difference in patient positioning. Here, the patient position is optimized. That is why eliminate this artifact. And here we could see the posterior breast much better than, we could see it here much better than this. All these artifacts were due to improper patient positions. And sometimes also you might need just to add more pressures. And by optimizing the positions, remind you that the breast, it will be what? Thinned. And the angle of the probe, it will be optimized. So you can see well the whole breast from the skin to the back of the chest. And you might need to change the position of the patient during scanning many times. Remember that. Okay. Regarding bulbable abnormality, this is essential. We said if the patient have a bulbable abnormality, she has to put her finger, and you have to put your finger in the bulbable abnormality, then scan it. Okay. And if she could not palpate it while lying down, let her to sit and palpate it. And this is examples here. This is the image for an examiner's, okay, putting the 3 fingers of contralateral hand, okay, under the probe, okay, to palpate the patient's concern or the clinical concern with coupling of gel, okay, and they describe it as if it is equivalent to having an eyeball on the tip fingers by doing like that. Okay. Ultrasound is interactive dynamic modality. These my cases, okay. This is bulbable abnormality. While asking the patient to put her finger, you might see something even, like not always representing a mass. This is only a fibrous ridge, okay? And fibrotic part of the parenchyma, tenting and pulling the superficial fascia, superficial layer of superficial fascia, and it becomes discrete or discernible, like a discernible mass. This is a bulbable abnormality in between the 2 breasts. If you did not ask the patient and put her finger in the bulbable abnormality, you might not see it. You might pass it, okay? Again, this is small area of bulbable abnormality, which was invasive ductal carcinoma. So really is really important, okay, to look and to ask the patient for the bulbable abnormality, and you have to palpate it yourself. Okay. Also, you remember we discussed before, we said the breast tissue extend to the midline, extend to the mid-axillary line, and up to the clavicle, to the axillary tail, and down. There are variations in the extent of the breast inferiorly or caudally. So we have to consider this while scanning the breast. Look, this is my patients. You see, this is invasive cancer. Look for the cursor here, is just below the clavicle. And if here, this is the muscles, you cannot see even obvious breast tissue. So you have to scan up to the clavicle. And this is in the far laterally beyond the mid-axillary line. Scan lateral to the mid-axillary line, okay? And this is in toward the axillary tail lesions. All these are my cases. Again, this is in the axillary tail. You see here toward the axilla, and how you can differentiate between lesions in the axilla arising ectopic breast from a lesion in the tail of expense or spence or the axillary tail. How you could differentiate that? We mentioned that before. Sahar? Suhair? Medina?
I think in the axillary tail, I can see a breast parenchyma within the area, and the lesion is within a parenchyma of the breast. While in the axilla, no breast tissue or no breast parenchyma.
You might see the ectopic breast in the axilla, and you find the lesion within an ectopic breast.
When the lesion is in the axillary tail, it will be continuous with the breast tissue. There's no.
Excellent. Yes, you are right. Yes, while you are scanning from the breast, don't raise your probe and jump to put it in the axilla. Okay, just sweep it continuously. If the breast tissue is not discontinued, okay, it's going with you, is from the axillary tail going up into the axilla, and the breast tissue is continuous, so you are dealing with axillary tail lesions. But if it is ended and then the area there is no breast tissue, and you went into the axilla and you find the lesions, this is most likely related to an ectopic breast, lesion within an ectopic breast. Okay? Okay, what is going on here? How many lesions do you have? Suhair, how many lesions do you have?
One lesion, I think.
One.
Who's talking? Who's talking?
Suhair, one lesion.
One lesion. Which one?
The above, the breast parenchyma, because the two shadowing area representing the chondro.
What about this lesion? What about this?
This is not a lesion.
This is what?
This is part of the cage of the.
Representing what? Yes, you are right.
The junction of the.
You are right. These are pseudo lesions. You are right. Yeah, these are costal cartilage, costochondral junction.
Junction, yes.
Okay? Costochondral junction or rib shadow. Okay, and why? Because this is a muscle. Excellent. You mentioned that this is
above.
Very thin breast tissue, but this is a fibroadenoma in the thinnest part of the breast, in its extreme medial superior, where the breast is fixed and thin. Okay, while these are behind the muscles, are seen behind the muscles, representing a pseudo lesions. Okay, but this patient having a cancer, okay, at the same locations. So far medial. That is why if this is not a bulbable, okay, it might be missed. So we have to go, while examining the patient, we have to go to the extreme medial, to the midline, okay, where the two breasts meet. So these all are my cases. You have seen this is just below the clavicle in the axillary, in the axilla, to axillary tail toward the axilla. Again, same in the axilla. This is at the mid-axillary line, same. And this in cancer in the extreme superior medial breast. Okay, so after we know that how to optimize space and position, we know to scan the breast from the clavicle down until no breast tissue could be seen inferiorly or caudally, laterally going to the mid-axillary line, medially to the midline, where the two breasts are abutting each others, okay? Then we would like to know what are the techniques to image a breast. First of all, we have to set the depths, or first of all, we have to select, sorry, I think this is not the slides. I have to. That is not the one. Okay. Yes, okay. First of all, we have to select the appropriate transducer, okay, for the breast examination. Then we have to select the to do pre-setting for the breast sonography. Pre-scanning, we have to optimize the depth or the field of view and appropriate time gain compensation or optimal gain. So we discussed last time the field of view and the depth. And if you remember, we said the transducer have two planes. You remember that? The longitudinal and the elevator planes. And we said the longitudinal plane is usually work, okay, or optimized by adjust the focal zone. Do you remember that?
Yes.
Okay, okay. And we said the elevator usually work at fixed number, okay, for each machine, but in the new machines, they also play in that part and optimize it. We'll talk about the elevation or elevator plane later, inshallah. Now we are talking about the focal zones. Regarding the focal zones, we have to preset it before scanning. And we have to put it where exactly? Do you remember how we could optimize? And the focal zone usually it represents what? When we put the focal zones, that means, okay, we target the lesions in the narrower field, in the narrower part of the narrower zone, okay, of the image of the transducer to avoid, to improve lateral resolution and avoid what? The volume averaging. So when we start scanning the breast, we screen the whole breast. By screening the breast, I need to see from the skin to the chest wall. That is why I will optimize it at the center. Okay, I'll put it at the center or at the mammary zone, so as the depth of the breast, it will be optimized to visualize the pectoralis muscles and the pleural reflections. As you have seen here, you see, this is, I can see from the skin down to the pectoralis muscle, down to the pectoralis muscle, okay? This is the focal zones here in the middle. This is the focal zones, okay? And while scanning for these patients, okay, at the same focal zones, we could appreciate these lesions. And we could see it well because the focal zone, the same focal zone, came at the center of the lesions. And here for these lesions, because the breast is thinned and slightly behind the lesions, that is why is also the image is good image and we could visualize the lesion well. Okay, regarding the time gain compensation or the set of the gain. So to optimize the gray scale, okay, we have to put it at a level that the fat should be at the mid-gray. Optimize the gray scale with the fat both in the pre-mammary and retromammary, okay, to be at the medium gray, So because we usually use the fat as a reference, any echogenicity similar to the fat, we said that it is isoechoic. If it is more than the fat or higher than the fat, we refer it to hyperechoic. If it is less than the fat, we'll say hypoechoic. Most of the soft tissue lesion or solid lesion are hypoechoic if it is darker than the fat. If it is black, we said this is anechoic in a case of a cyst. And if it is brighter, like Cooper ligaments, fibrous tissue, this is having more echoes than the fat. So we have to adjust this dynamic range to have the fat at the medium gray. What is the significance of that? If it is low, will result in inappropriate image and inappropriate characterization of the lesions. If it is high, it's also the same. So setting the dynamic range too low, it will increase the contrast, the image contrast. That is the difference between hyperechoic and hypoechoic. It will be much difference. And this will remove the echoes within a soft lesions, okay, and simulate the cyst as seen in this image. This is, okay, this is invasive cancer, hypoechoic lesions. But if you look here, as if it is a cyst, it is deeply hypoechoic, or as if it is anechoic. So the gain is incorrectly too low. How we understand the gain is too low? It is a reverse for the contrast. Look for the contrast, the difference between the fat and Cooper ligaments, everything, it looks like a black and white. The overlay pride image, devoid grayscale. Okay, variations. There is no grayscale variations. Okay, that is only what we have seen as black and white. When we see black and white, the contrast is too much. That means we adjust the time gain in a low setting. We have to adjust it because the soft tissue, it will mimic a cyst. And the reverse, it will occur when we optimize the dynamic range, okay, in a higher level. Generally, it should be, the dynamic range, it should differentiate tissue without losing contrast resolution. In this case, if you have seen here, this is the reverse for the previous image. There was the contrast is very high. Here, there is no contrast. The image is blurred. Okay, there is no much contrast between the breast tissue, and there are artifacts inside the cyst. There is reverberation artifacts, and the cyst here is seen as as if it is a fibroadenoma, as if it is a soft tissue. When the the gray scale is being optimized, okay, then it will become anechoic, because we have to refer it to the gray, medium gray of the fat. You got it?
Yes.
Okay. So we have to adjust it, to adjust the time gain correctly so as not to lose the contrast. Okay. After we set the depths, we optimize the gray scale, we have to use the acoustic gel, okay? And then we have to select scanning pattern. What are the scanning pattern for the breast ultrasound?
Either clockwise or can radial.
Excellent. Rehab or whom?
Rehab.
Oh, you are welcome.
Hello, يا boss.
Thank you. Thank you. You said what again?
Clockwise or radial?
Clockwise or radial. Okay. So we have one technique is radial and radial. Excellent. This is one technique. There is another technique. Okay. Which one? Radial and radial one. The other one is
circular.
what? Circular. Usually circular is the radial one. When you scan radial, you will go circular.
Longitudinal and transverse.
Excellent. Well done. What is the name of this longitudinal and transverse? Excellent. You are ahead the مش كده?
Yes.
Yes. What is the name of it? You remember? Do you remember? Okay. 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 So we have two techniques. Generally, we have two techniques for evaluation of the breast. Minder, like, or grid scanning. This is the longitudinal transverse. Okay. And this is a commonly used technique. Either by quadrant, or if the breast is small, you can use it for the whole breast. You can put the transducer here in transverse, going down and repeat it across, up, down, up for the whole breast. But if the breast is big, do it, okay, quadrant by quadrant. The same. Go down and up in the quadrant, complete the quadrant, and then go to the other quadrant. And don't forget to scan the retroaerial. So we have 5 zones: upper outer, upper inner, lower inner, lower outer, and subareolar region. 5 zones. If the breast is big, go through the 5. If the breast is small, you can go through the whole breast, okay? At the same time, with overlapping, you have to overlap so as not to miss lesions. When you complete up and down transversely, just rotate your probe or the transducer perpendicular to the first and scan it in longitudinal directions. Go, okay, like this from right to left, transversely, also is overlapping. Sweep, after you sweep superior and inferior, here sweep, okay, from side to side with overlap. You have to overlap. And again, if the breast is small, you can go throughout the breast. If the breast is big, go quadrant by quadrant. Okay, this is a great pattern or Minder-like pattern. The other technique is a radial and radial technique. Then this is the radial technique. Okay, it is the same as clock face technique. The radial and radial, it is the same name is a clock face technique. So in the radial and radial, generally we start at 12 o'clock positions in a sagittal plane with the toe of the probe at the nipple. Okay, and then you will sweep in a circle, rotating around the nipple, going around the nipple. When you find any abnormality, then rotate your probe 90 degrees, then it will be in an anti-radial locations. Okay, so this is a circle, clock face, circle, radial and radial, all are synonymous. Okay, which one? Could you hear this noise? I don't know from where. Okay. Which one is good? Which one is preferred? The clock face, radial and radial, or the Minder technique? Which one is preferred? Okay, let us see together. Radial and radial generally is preferred over the grid or Minder technique because scanning along the mammary duct and lobar tissue. So it will allow understanding the lesion site and ductal extension and delineate the ductal system. Okay, because when we put the transducer in a radial directions, this is the directions of the ducts. If you can see it here, this is a transducer here along the ductal system. That is why. While this, the Minder technique, okay, or grid technique, it will be transverse or longitudinal. It will cross the ductal system. And if you imagine these multiple ducts large lactiferous going toward the nipple like this tree. Okay. But this الو الو
ايوه يا دكتوره رباب،
أيوة
صوتك
أيوة
كده كده واضح.
وقفنا وين؟ وقفنا وين؟
في
وقفنا هنا
الصورة
في
دي تحت
Okay, I will start from here. I said the radial is more important than the grid technique. Why? Because it aligns along the axis of the mammary ducts and lobar tissue. And the lesions, you know, in the breast are arising mostly in these areas. So it will allow us to understand the lesion sites and delineate its extent along the ductal system. And we said that if you look here for the transducer, this is the radial. You got it? This is the radial along the ductal system, while the grid is either transverse like this or longitudinal, okay, or vertical. And we said if you look for these three, like lactiferous duct with its branching, okay, look for the branches throughout the breast. And if you look here, are you hearing me?
Yes.
Okay, and as you know, the lactiferous ducts, we have about 15 to 20 lactiferous ducts, okay? So these trees representing multiple lactiferous ducts and their branchings. And look for the branches, you see, this branch coming in that directions, and there are a lot of overlapping. And this is illustrations for the ducts and ductal system, okay, pointing toward the nipples. Just I brought this to imagine this overlapping. You got it?
Yeah.
Okay. If we look here for these illustrations, these are the ducts and their branching going toward the nipple. These are major ducts, and these are terminal duct lobular units here, okay, and even have smaller ducts. But if we look for these ducts and their directions, look, this duct in these directions, while this duct directed like this, while this in that directions, like in these branches of the tree. Okay, so while scanning radially, not always along, okay, the ductal system, but we can when we have a lesions, okay, this is the Minder technique, and this is the radial technique. If you have a lesions, just rotate your probe to the maximum dimension of the lesion. When you got the maximum dimension of the lesions, that means you are in a radial directions of that duct. You got it?
No.
Generally, you did not got it. Okay. You did not get it. Okay. What I have said, you understand this? You understand what I have said here?
Yes.
Not all ducts
Are
and
directing towards the nipple.
at the same directions.
Yeah.
So not always while I'm scanning in a radial, when I'm scanning, generally for the major ductal system, I'll be aligned. But for the minor one, no. Generally, what I am doing while I'm scanning in the I used to Minder technique, Minder-like scanning. It is more easy, more quicker for me to do it going through while I'm screening the whole breast. When I identify a lesions, Then I used to go for the radial and radial technique. I scan the lesion in a radial technique, but sometimes when I put the transducer in an optimum radial technique pointing toward the nipple, the lesion might not be in the longest axis, longest dimension.
Yeah. Mm.
If it is not in the longest dimension, that means it's not oriented. This is not the orientation. This is not the radial directions for the lesion.
Yeah.
It is radial for the breast. And we prefer the radial because it is along or aligned along the long axis of the duct. But in this case, if I could not see the maximum dimension of the lesion, that means I'm not along the long axis of the duct related lesions.
Mm-hmm.
I will rotate, I will angulate, okay, my transducer more obliquely until I could reach the maximum length, the maximum dimension of the lesions. When I got the maximum dimension of the lesion, that means I am in the radial for that duct. Radial alignment of the ducts. You got it now.
Yes, yes.
Okay. So here, this is the minder. This is a lesion in the minder technique. And this is the same lesions in the radial technique. And when you see a lesions in the radial technique, you have to rotate your probe 90 degrees to see it in orthogonal view. And in this case, it will be the antiradial directions. Antiradial is 90 degree to radial. Okay, so as we mentioned, it is good for a lesion related to a ductal system. And this is very helpful when you scan the duct in a radial directions or in a radial technique, radial and radial. It will help us to evaluate for the ducts and lesions related to the ducts and its extent. And don't forget to put the probe perpendicular and do antiradial technique. So the accepted views are long and transverse, which is minder technique, and radial and radial technique. Okay, and the ultrasound of the breast protocol should be a minimum of 2 scan plane in a whole breast are recommended or is recommended. Okay, and most common to initially scan using the grid scanning technique, followed by radial and radial technique. And this is what I used to do it in my practice. I used to start by the minder technique or grid technique or long trans technique. Okay, then when I find area of interest, I try to shift to the radial and radial scanning. And as per the ACRIN 6666 protocol, a normal screening ultrasound examination should consist a minimum of 1 image in each quadrant and 1 behind the nipple. As a minimum, when you take an image for the breast, you screen the whole breast, not a targeted ultrasound. If you screen the breast, you have to take at least single image for each quadrant. And as we mentioned, we have 5 zones. We have 4 quadrants and we have subareolar regions. Okay, so we have 5 zones for each quadrant, and for subareolar, we have to have at least 1 image. And apart from the abnormal area, we'll talk later about the area of abnormality. So after we set up the ultrasound system and we use the gel, we select our scanning pattern. So we have to mention important issue, which is gentle but firm transducer pressure is essential for evaluation, for breast evaluations. And we might have varying degree of pressure used to flatten the breast parenchyma and to bring the conical surface of the glandular tissue into more orthogonal planes. Okay, let us see. This is general. When we identify lesions, okay, then we need again to readjust the ultrasound system. We have to adjust appropriate field of view for the lesions. From the beginning, we adjust the ultrasound machine and we adjust the field of view to have a look throughout the breast. But when we identify lesions, okay, then or an area of interest or a potential lesions or subtle findings, then again we need to reset or to, the ultrasound machine to optimize the image, including again the field of view or the depths. It depends. If the area of interest is superficial, we need to raise it up, the field of view, to move it up, okay, to visualize that area or to make it very sharp and clear. And if it is deep, we'll move it down also to bring the area of interest at the narrower zone, okay, narrower field of view for the transducer to avoid what? Blaring.
Averaging.
Volume
Volume averaging.
To avoid volume averaging, okay? And if we have multiple focal zones, it will help us to show multiple depths simultaneously, more clear and more sharp. But if we have a single focal zone, then we need to center it at the lesion or the area of interest or slightly behind it, okay, to make it sharp. And we need again to readjust the time gain to make sure the contrast is optimum, not over or under to give artifact or to reduce or to eliminate the internal echoes within a soft tissue lesions. This is an example here, okay? There is an area of interest, optimize the image to see even posteriorly. You see, this is my case. This is invasive cancer. And here going back, this is the muscles. Not very sharp, but at least we could see it. We adjust the focal zone here, okay, at the center of the lesion or the area of interest, and we could see the infiltration into the posterior muscles was proven surgically. And this example from a literature, a breast cyst with the calcification. Look how it is sharp and the calcification very clear because of optimization of the focal zones at the center of the lesions. Okay. What about this image? Which one is optimum? Which one is not optimum?
The left side, it's more optimized.
More optimum?
B, the B1. B.
B is, who is talking, Rihab?
رحاب أيوة.
You are welcome today, يعني very bright.
بناتي ما معانا برا عشان كده.
Oh,
العربية. عشان كده.
you are welcome. You are welcome.
Sorry.
Okay.
B is
Yes,
more.
you are right. You are right. What is wrong with the first image?
It has an image with no the border of the lesion is not clear, with the internal echoes appear on the other one. It's so clear.
How you know? It might. This is not the correct one, and this is the correct one.
It's even the surrounding tissue. Even the surrounding tissue.
the same lesions. Here, performed by one operator. That is why we said ultrasound is operator dependent. This is by one operator, and this is by another operator.
Even the normal breast tissue appear more clear on the on B. Even the normal breast tissue.
Yeah, it reflects what when we said that more clear. So
this is more optimized. B1 is more optimized.
Regarding what? Regarding
the focus of the image.
or grayscale. We are talking here. We have two main. We have two main points.
For me, I think both of them.
Focal zone, and we have the. If you look
TGC.
here, you look here. Yani.
The focal zone.
You are talking. You are okay. If you are talking about the focal zones, what it will affect, it will be focalized.
Yes.
Focal area. Now you are talking
about TGC. The TGC, yes.
The TGC. So you are talking about the grayscale, the dynamic.
Yes.
Okay.
Yes.
The TGC. So we said it have to be optimized to have an optimum contrast, not to be over hyper contrasty image, black and white, and not to lack the contrast. If you look here, there is lack of contrast. Everything looks the same. And even the resolution is being affected. But this is good. This is gray, medium gray. The fat is medium gray in the pre and in the retromammary region, and even the fat within the glands. It looks medium gray, almost the same. And the difference, that is why the echogenic fibroglandular tissue from the fat, now here there is contrast. And even look for the skin. Okay, skin here is more sharper than here. That means this image is optimized. So I will consider this one, this lesions is anechoic and reference to the fat. That means this is the simple cyst. This is not the correct one. Okay. Now you understand the image, which one is the optimum one, the quality of the image. Okay. So again, scanning the breast lesions, we have to use varying degree of pressure. We mentioned before, generally for the breast parenchyma while scanning, we have to have a gentle or varying degree of pressure for the parenchyma, okay? And also when we find the lesions, sometimes we need to just give some pressure to flattening and angulate while the pressure, you see, and see it and sweep through it. It will give us, it will help us to evaluate the margin of the lesion, and especially in case of a cyst, okay, by compression and angulation of the probe from heel to toe, it will sharpen the edge of the cyst, okay? And when it compressed, when it appear hypoechoic, and if you give pressure and it get compressed, that it will help us in evaluation of its cystic natures, okay? And also we might add a harmonic to evaluate for the cyst, but not only for a cyst. We'll see later how compression is also helping us. Before I forget, in a pseudo lesions of a fat lobule, sometimes, yes, the fat lobule, it might see as a discernible mass when we angulate. It is just, it become elongated and mixed with or seen in continuation with the rest of the breast tissue, and we'll make sure that this is fat lobule. But sometimes the fat lobule, it becomes within a fibroglandular tissue as an island like that. You see, as if look like a mass. Also here, if it is a little bit anterior or superficial by pressure, okay, it can give some flattening. It can flatten to some extent. About 30% or something might get some deformity and flattening, so it will help us to differentiate it as a pseudo lesion from a true lesions. And here look for the, with some pressure also the cyst can be delineated and sharpened and make sure it's cystic natures. But you know that nowadays also we can use what to make sure this is a cyst?
Elastography.
Excellent, elastography. But not always elastography being used, okay, for the cyst. If it is very clear, simple cyst, no need to use elastography. But for indeterminate cases, if the margins are not very clear, or there are artifacts, reverberation artifacts within the cyst appear as if it is a complicated cyst, then we can use elastography. And here, this is a typical appearance of a cyst.
Pulse eye.
Pulse eye. And even smaller compared to the grayscale image. Excellent, well done. It's okay. What is the difference between these two images? If you look here for the cursor, okay, it looks more or less the same locations. Look for the image. What happened here? What is wrong? Look for this. It is written here. It is written there is glandular tissue simulating breast cancer. Look for this glandular tissue here, amalgamated together, giving shadowing, very thick, absorbing the sound. By giving pressure, okay, by giving pressure, make it thinner, let the sound goes, and everything getting clear. So this is image with pressure, and this is image without pressure. You see, sometimes pressure is really helpful to clarify lesion from a pseudo lesions, and like in fat lobule, and like in amalgamated or pressed glandular pressed tissue with shadowing, absorbing due to sound absorptions. Okay. Again, when scanning and a lesion is identified, we have to use all available technical facilities in the machine to maximize the quality. We have to use a harmonic, Doppler, elastography, speckle reduction, compounding imaging, as well as microcalcification imaging, as we described in the previous sessions. Look for this image. This is our patients here, okay? Look for these shadowing lesions, but by adjusting, okay, the parameters in the machines, we could eliminate some of these shadowing and visualize at least the posterior extent of the lesions. And also here, by the using the convex probe is helping us to visualize the whole lesion, and we could measure it well. What is your impression about these lesions? How we can label it, or just to describe it?
Okay. Irregular mass with heterogeneous echogenicity, partly cystic portion and partly solid.
So when it is cystic solid, we call it?
Mixed, complex.
So this is a circumscribed, lobulated, complex, but the margins are not sharp. Okay, when we talk later, inshallah, about the criteria of ultrasound breast lesions, we'll differentiate between circumscribed sharp to circumscribed unsharp. Sometimes the lesion is a circumscribed, but still having a fuzzy border, not sharp border, as is seen in these lesions. Okay?
Yes.
And
Yes.
it is complex. So how you are going to help yourself looking for these lesions to make sure this is cystic part, not
At Doppler.
Excellent, well done.
يعني
Then we have to use a Doppler. Yeah, when we use a Doppler, so this is not a complicated cyst. If we look at it here, we might see even this part, just it can be an inspissated debris sometimes, okay, within a cyst. But because it is here, it is so homogeneous. But when we put the color Doppler, this part is highly vascular. So we are dealing with a vascular
malignancy. Yes.
Is it malignant? Are you sure it is malignant? We can say a suspicious. We can
suspicious,
say
yes.
Yeah.
Great.
But there is no in the cystic part. I could not see at least vascularity. That means still it is probably complex lesion. What else can help us in evaluation of this lesion?
Elastography also can help.
Elastography. Huh?
Type,
so, how
yes.
does it help you, elastography?
Yes, a great part of the lesion is hard, and the lesion in elastography is larger than the lesion in the grayscale.
Excellent. You are excellent. Well done. Excellent. Yeah. All right. So even what apparently cystic here is hard. It appears hard on elastography. So this is mostly a non-cystic area, is probably necrotic part rather than just cystic part. See, this is apparently cystic there. It is also hard and it is large. So upgraded by elastography, upgraded this lesion. And this is one of the mimickers, one of the breast mimickers. Okay.
Okay.
It was just a focal fibroadenosis. Okay, it was not. This is my patients. It was not a cancer. We put it as BIRAD. We report. I have been reported as BIRAD 4A because it demonstrates minimal increase in size and more or less stable characters over time, just reported as BIRAD 4A and biopsy. And one of the differential diagnoses, we mentioned that it could be because the patient having a fibrocystic changes. We put one of the differential is fibroadenomatoid changes and proven pathologically. Okay.
Okay.
Then when we identify lesions, we have to, as we mentioned before, we have to rotate the transducer 90 degrees to have an orthogonal view over the area of interest or the lesion. This is very essential to characterize the lesion and to distinguish from a normal tissue as a pseudo-lesion. Okay, and we have to remember that Cooper ligaments sometimes can appear as a honeycombing, and fibroglandular tissue within this area might mimic a mass, as we have seen in the previous examples. And here, when this is a small lesions, when we angulate the probe 90 degree, look for the extent of the lesions is larger, the maximum extent when the transducer is perpendicular or in the orthogonal view. This is the importance of the orthogonal view. We have seen a case earlier. This is, if you look here, look for the muscles. But if you did not concentrate and you have seen the muscles, you cannot imagine or you cannot think about this area to be just costal cartilage or a rib. But when you have to angulate your probe to evaluate any lesions. When you angulate your probe, you will see it now is getting elongated, going along the chest wall. Okay, and this is my case with the patient having a palpable abnormality, and said we have to put your finger and to make sure the exact area of bulbable abnormality before you scanning the area. And while scanning, you have to make sure your transducer exactly over that area. When we scan, we could see this is just area of a fibrous ridge.
Yes.
This obviously this is a fibrous ridge. Okay,
Yes.
tenting, the parenchyma is tented, and even here attached to the superficial fascia with minimal pulling. But yeah, minimal tethering, excellent. But we have to rotate the transducer, and we have to make sure this area of the parenchyma, okay, it is purely clear parenchyma, nothing else. We have to follow the rule, not just put the transducer, and this is a bulbable abnormality, and we have to make sure if you look for this and put your finger, you expect the size of bulbable abnormality to be like
Small.
very small. But the bulbable abnormality was a little bit larger. So I have to correlate. The bulbable abnormality was not as small as should be in this image. So I have to sweep throughout. When I sweep, look, within the same area, there is a fibroadenoma. Okay, look for the area, same fibrous ridge. Within this parenchyma, there is underlying fibroadenoma, which was the bulbable abnormality, not the fibrous ridge itself. So we have to make sure, we have to manipulate and rotate and throughout the area, sweep throughout the area, at least 90 degree, okay, orthogonal view, to make sure there is no, and to differentiate between normal tissue and pathology. Again, this is our patient. Look here, the parenchyma is coming and elevated. So we said, yes, sometimes the parenchyma look like or mimicking lesions. What I can see, small cysts here. Could you see any abnormality in this image? Any lesion in this image? Yes, this definitely the parenchyma here is going parallel, then here elevated. Okay, humping. So it can be bulbable, smooth bulbable. Large area of bulbable abnormality can be here because here a little bit elevated from the rest of the parenchyma. Here is not very parallel as the rest of the parenchyma. Is humping, but a smooth hump. So some, as we mentioned, some pressure, minor rocking of the transducer sometimes is helpful. Rotate, sweep, okay, until you could see a 3-dimension of a lesions or of a suspected mass. When we rotate, can you see any abnormality here?
Yes.
What?
Yes.
So start to see, and here more. So
Yes. More obvious.
Yes.
there is a lesion. There is a probably benign lesion, which was a fibrocystic changes. Okay.
تشبه البريست within breast.
Yeah, like a hamartoma. Yes, fibrocystic changes sometimes. Yeah, it came like this, and hamartoma or fibroadenolipoma is also having the same appearance. But at least from the beginning, you might overlook it. But if you are following and considering appropriate technique, then you can find the abnormality. And if it is not palpable, definitely we'll pass it, will not get it. The importance, again, continue importance of orthogonal view and sweep along the margins of the lesions. This is a suspicious lesions here. When the lesion identified, we said after resetting and optimizing the scanning technique, we have to sweep through the entire lesion in multiple planes to clarify this margin and to characterize it well and to make sure is a true lesions. This definitely is true lesion, not like the previous one, but at least we have to characterize this lesion and to see its extent. Look here, by orthogonal view, then you can see the ductal extension up to the nipple regions. Here is suspicious lesion. Here with this ductal extension, I will upgrade it from 4C to Barat 5 by these ductal extensions. Okay, so really is important to sweep and to angulate throughout the lesions. Again, all these are my cases. This is definitely suspicious lesions. Okay, indistinct with echogenic halo, some speculations and angulations is suspicious. When we sweep throughout, look how the lesions, okay, is even much larger than in this image and much ugly, okay, and much more suspicious than in the first view. Again, when we look, this is definitely suspicious lesion, microlobulated, angulated, and so on. So with posterior enhancement, but it is an heterogeneous like that. It's suspicious, but I can say phylloides tumor or cancer. But when I have seen sweep throughout, look for the ductal extension, look for ductal extension, and I have to look and sweep, look throughout. This is another ducts branching, even is branching. Look for the extent of the ducts and the satellite lesions. Okay, so this is definitely Barat 5. More ducts, this is different angles. This is another duct. So this lesion having multiple ductal extension in different directions. Okay, at different directions there are multiple ductal extension and satellite nodules by Barat 5, and it is invasive cancer until proven otherwise, and it was proven invasive cancer. Okay, and what is going on here? This is again a heterogeneous lesions, is suspicious lesions, but when I have seen also the ducts, irregular ducts, okay, going down to the nipple, and even here a papilla within the nipple is stretched and dilated. So this is that means if it is seen only here, it will be BIRAT 4C, but along with this ductal extension, definitely it will be upgraded for BIRAT 5. Okay. What is the name of this image? I'm talking just about this part.
Yes.
Technique for this image.
Mm.
Can I measure the duct? Can I measure the duct here?
Mm.
Can I measure this duct? Huh?
Mm.
No.
Here.
Could I measure it? Huh? Could I use this image? Could I use this image for measurement?
No.
No. Who said no? Muhammad?
Yes.
Why no? Excellent. Well done. Why?
Split view, double images parallel to each other.
Excellent. Well done. This is split. We call it what? It has a name. Technique. The technique we said last time, we have
Panoramic.
multiple.
Panoramic view.
Panoramic.
This is not the panoramic. If it is panoramic, I can use it for measurement. But there are other type other than panoramic. We said we have many types of extended view. We have extended view. We have many techniques for extended view. The panoramic, we can use it for measurement. But the other two, we cannot use it for measurement. The other two, the trapezoid, we can use it for measurement. But this, we call it appended or image. Appended, or double field view, we cannot use it for the measurement. It's not an appropriate for measurement, but it is helpful to give us an overall pictures or for the lesion and for the extent without an accurate measurement. This is different image, but these are split image. Okay, thank you very much. Okay, so again, if we could identify a lesions, sometimes we might need to use an offset technique. What is an offset technique? Or acoustic stand-off bad technique.
Yes, applying a thick gel to see the lesions that are superficial.
Why we could not see it well?
Because sorry?
Why we could not see it well?
يعني when we have a high resolution probe, we can see it. يعني if we have a probe, for example, 18 megahertz or so, we can see it. But if we are using the probe that is 12, then
no, even what matter high resolutions, skin lesions and nipple lesions are dermal lesions are difficult because it's still difficult to be, if it is seen, is difficult to be evaluated because of volume averaging. Why? As you remember, I told you we are going to discuss it later. We are going to come for the, we said the transducer have two planes, the longitudinal plane working in the focal zone, but the elevation plane is fixed for the transducer, and for the superficie, for the high transducer, generally it is about 1.5 centimeter. That means the near zone or the narrow zone, yes, it's near, but it's not as near as the level of the skin lesions. The narrow zone, if you remember the image, I did not brought it again. I did not bring it, sorry, I did not bring it here again. The area of a narrower zone for transducer, this is where I could see the lesion is very sharp. And that is why, this is the area where the elevated plane is working. And for that is why we said for the low frequency transducer, usually the narrow zone is much deeper. That is why we'll see the posterior lesion better than the superficial or the high transducer, high resolution transducer or high frequency transducer. And for the high frequency transducer, yes, we can see the near zone or the focal or the narrow zone is near toward the skin, but is not very superficial. Still, it will be within the wider, a little bit wider area. The skin area, it will come at the wider area. When we put thick gel, 1 centimeter or so, we will make the depths, we will increase the depths to make the lesion at the, or to bring the lesion or to move the lesion, okay, to the level or to the elevation plane focus. You got it?
Yes.
Yeah. We add depths for the lesions. We add some centimeter, okay, to make the lesions at 1.5 centimeter where the elevation plane focus of the transducer. So this is my cases. This is young lady presented with nipple retractions, and here this is a duct in a chronic ductectasia. Only she has chronic ductectasia causing this. So to visualize very well this superficial area, look for the focus, large amount of gel here, okay, to get it closer to the elevation plane focus of the transducer. And this also here, look for the gel, the abundant amount of gel. And to see this skin irregularity, you see, without putting gel, it will not be visualized because the transducer, it will abut the skin. You cannot see it well. Okay. You know that the breast cancer in subareolar region is about 20%. And evaluation of this area is required in workup of nipple discharge, nipple inversion, and other common pathology, and to exclude breast cancer. So special attention must be given to the nipple and nipple areolar complex. And evaluation of this is really challenging because when you put the transducer, the nipple push into the breast substance, and it can appear as vague shadowing nodule, as a pseudo lesions in the subcutaneous area. Also, the nipple causes extreme shadowing, okay, all limiting the visualization behind the nipple, the subareolar region. And the tightly packed ducts in the breast are parallel to the ultrasound beam, so also make it difficult to be visualized. And we mentioned one of the important technique to visualize the nipple and subareolar region is standoff gel pad, okay, or focus within an offset. This is one of the technique being importantly used for evaluation of nipple areolar complex. But we can use also other techniques to evaluate the nipple area, and especially to visualize the duct by, you see, rolling the nipple, using the transducer itself to roll the nipple. Okay, try to roll it and angulate the transducer. This, it will improve the angles of the ducts, and especially if you angulate in a radial way, that you can parallel or you can align along the long axis of the ducts, and it will improve its visualizations. This is my patients having a lesions, okay, within the nipple. If I remember, it was a nipple adenoma, okay. By using large amount of gel, we could visualize, we could clarify it. Here, if you can see it here, the gel, the amount of gel not very clear, and the abutting, the transducer abutting not much visualized, but by giving more gel and angulate, along with angulations, not only putting the gel and angulate the transducer, so we could clarify these lesions. The patient having a palpable nodule in her nipple. Okay, another technique helping to visualize or to evaluate the nipple area is to support the nipple with the contralateral hand while you are pressing or you are pushing by the transducer, as seen in these illustrations here. As we mentioned, usually the nipple is compressed, is pushed, is slipped away. So to give support and to stabilize the nipple so as not to move, and to optimize the nipple transducer geometry as well as geometry of the ducts, just hold the breast with your contralateral hand and try to push with the transducer. Okay, this, it will give a highest quality image in that area. And ductography. Ducts not only in the retroareolar region. If you look for this here, this image, trans left 3 o'clock, 8 to 9 centimeters from the nipple. So scanning in transverse, okay, and in the left breast at 3 o'clock positions, about 9 centimeters from the nipple. So sometimes we have a segmental ductectasia. We have ducts, dilated ducts away from the retroareolar region. And with a high frequency transducer, generally visualization and clarifications and evaluation of the ductal system is improving, really improving, and become visible. And not only to see the duct, but also to see inside the ducts, and even to see the margins. Look for these lesions. This is a duct, soft tissue with calcification and breaking through. In a case of, from the image, I can say, I can raise the possibility of invasive cancer because I could see the image even breaking through the ductal and extending into the adjacent tissue. So it will be suspicious for DCIS with invasive component, and it was proven pathologically. But generally, as a rule, we have to consider the radial scanning for the duct. But it is mandatory to scan the duct in a radial technique, with a radial technique. Okay. Remember to scan the axilla. Axillary tail is part of the examination of the breast. But the axilla, most of the time, considered part of the breast because the drainage, definitely the drainage of the lymphatic drainage of the breast is toward the axilla. And when you have seen any suspicious lesion in the breast, you might go and scan the axilla. For me, I was routinely scanning the axilla as part of the breast, but not everywhere. In all centers, they are scanning the axilla unless there is indication for that. And we described before, we said when it is deep the axilla, we might need to use the low frequency transducer. And also we have to optimize the image for the axilla in the same way as optimizing for the ultrasound for the breast. These examples of a normal lymph node, and these definitely are malignant adenopathy. See? Okay. Again, in conclusion, when scanning breast lesions, when breast lesion is identified, we have to re-optimize the image. We have to optimize the image, I mean, by resetting the machine, though currently in the modern machines, auto regulations or automatically, it can be optimized, okay? Then we have to use compression and angulation of the probe to sharpen the margins, and we have to use all facilities to maximize image quality and to sweep throughout the entire lesions in multiple planes to make sure and to evaluate the lesions, to make sure it is a true lesions, and to evaluate the lesion itself, especially its margins. And then we have to use acoustic standoff bed when it is needed. And then we have to give accurate measurement of the lesion size and to give to do lesion labeling and image of the lesions, okay, in the radial and radial view should be captured and annotated. For lesion, for the labeling, we said for accurate understanding of lesions location or lesion origin, we have to use radial and radial. When you have a lesion, while you are scanning using longitudinal transverse or Minder technique, if you identify lesion, just go or shift to radial and radial, and then capture image for the lesion and do your labeling. Okay, this is the directions of the ducts and the radial at the same times showing the clockwise. Okay, we said it is a clockwise. Okay, lesion annotation scheme. Appropriate labeling and of the lesion location is imperative in determining the correspondence between sonography and mammographic abnormality. Okay, and also the follow-up imaging, biopsy, and surgery must have a reproducible system of lesion localization. It is essential to label the location of the lesions. So when we identify a mass, lesion, or any abnormality, we mentioned that we have to document it in a radial and radial pattern and the annotated, and we have to capture the image. And then we have several labeling for the location of the lesion. First of all, we described before, as on mammography, we have to mention the laterality In which side of the breast, right or left? We have to describe at what o'clock. Okay? We have to describe. Sometimes we can mention even the quadrant. If we mention the clock, that means it's understandable. Sometimes they describe by quadrant, I mean quadrant locations. And sometimes also used the distance from the nipple, which is more constant. Okay, so the breast image in routine manner, labeled as if the hands of a clock. Usually, okay, the 12 o'clock is a kefalat and 6 o'clock is a kodat. You know that. When you look at the breast, it's like that. The highest point is central, is a or kefalat part is at 12 o'clock. Corresponding same level. Caudally or the inferior part is 6 o'clock. And we have to note the axillary regions. And we have to have imaging at 12 o'clock, 2 o'clock, 4 o'clock, 6 o'clock, 8 o'clock, 10 o'clock, nipple, axillary tail, and axilla. And we have to document any pathology in 2 planes. We have to include measurements. We have to include if there is any vascularity or elastography to be documented, not just to mention in the report. We have to capture the image, okay? And we have note the size, depth, and distance from the nipple. We'll go through that. It's okay. Regarding the locations, okay? Here, the N is the nipple. Usually, they abbreviate it as N for the nipple. Abbreviate subareolar region as SA and the axilla as AX. Okay. We have 3 concentric rings. These 3 concentric rings representing zones. Okay. Zone 1, zone 2, and zone 3. Okay. The zone 1 is the closest to the nipple, but is not at the nipple area. It's not behind the nipple. Nipple is not included. Okay. The area near to the nipple is zone 1. Zone 2 in the middle, and zone 3 is the peripheral. Okay. Divide the breast into equal 3 zones around the nipple, and then middle, and then peripheral. And you can describe the lesion is at zone 1 or zone 2 or zone 3. But remember, the nipple or the nipple area or subareolar region is not included in this zone. If the lesion behind the nipple, mentioned it is subareolar, not to mention in zone 1. Okay. And if in the axillary tail, mention the lesion in the axillary tail or in the axilla, not to mention at zone 3. Okay. And we have the clock face, as you have seen here, from 12, and this is 3, and this is 9, and in between, same as the clock, you know. And the mass given by the area M here, it is seen at what o'clock? This is the right breast. It is seen at
10 o'clock.
10 o'clock. This is 10 o'clock. They put R10-3. That means it is right breast at 10 o'clock at zone 3, because it is here, it is at the periphery. It is zone 3. This is zone 1. This is subareolar. Zone 1, zone 2, zone 3, and look for the axillary tail and axilla is not included in zone 3. Okay. And some authors, they prefer to describe by the nipple by the distance from the nipple. Okay. And we have to, if you are using these illustrations, you put your transducer, if it is vertical, if it is horizontal, if it is radial, if it is antiradial. Or you can write trans, long, or radial, antiradial. And also this is the probe directions. And sometimes we have to mention also the depth of the lesions, okay, in relation to the skin. Sometimes is important, but not always. Okay, here we can just have idea with these illustrations. These are the 3 zones, okay, and this the depths of the lesions. Also the depths by zones. Zone A is anterior, B is middle, C is posterior. Posterior is close to the chest wall, and so on. So also we can describe the lesion as on mammography by these zones are more or less corresponding to the zone on mammography. And most ultrasound department use the clock methods to label their lesions, along with the ABC, the depths, and 1, 2, 3 annotations, helpful exactly the exact lesion location. Sometimes is needed to understand exactly the lesion at which locations. This sometimes is helpful for if they would like to take a biopsy or correlate it with other modalities, especially in multiple lesions. Okay. This image demonstrates the lesions at anterior, middle, and posterior, and their distance from the skin. And this, the distance here from the nipple, will not measure it like that. Okay, we'll measure the distance, we'll make perpendicular line toward the skin, and then from the skin to the nipple to measure the distance from the nipple. Look for these lesions here, the distance from the nipple, and this one, the distance from the nipple. And these lesions here, okay, is just, this will say this is subareolar or behind the nipple, okay? But this one is far from the nipple by about maybe 5 centimeters, 6 centimeters, or so. And we have to label this in, or to annotate it in our image. So freeze the image, annotate by press size, side, right, left, clock position, scan plane, zone, and structures, then save your image. And if there is any bulbable abnormality, so the bulbability and imaging correlations, if documented, then definitely it will complete it. And careful attentions, it has to be for clinical concern. We have to make sure we are talking about the same lesion of the clinical concern. Regarding the measurement, we have to measure the maximum dimensions. So sometimes we might need, as we mentioned, we might need to oblique our transducer more. Not only we will put it in a radial direction. If, and then we angulate and obliquity or obliquing the transducer until we get the maximum dimensions of the lesions, then measure the maximum dimension, and then take a perpendicular, okay, measurement for the maximum dimensions. Look for the measurement here, the maximum, then perpendicular to the maximum dimensions. Again, look here, this is the maximum. This is the maximum. Okay, so oblique your transducer until to get the maximum dimensions for the lesions, and try to take, okay, at least you have to document 2 orthogonal view for the lesions, and take your measurements in the long and short axis, like in this image, okay, with annotations. And we have, and in case of larger lesions, we can use which view? This view now?
Panoramic view.
Extended view.
Excellent. This is a panoramic view. This is here. This is a panoramic view. Then we can use it for large lesions to get to measures. And we have to document image with measurement and without measurements for the lesion. Not to take all the image just with the measurement and that is it. For the same lesion, you have to have image with measurement and image without calipers, without measurements, without. Okay. When searching for a lesion initially identified at mammography or MRI, we have to carefully correlate it with the lesion in ultrasound regarding the depths and surrounding anatomic structures. We have to have good attention to the surrounding background tissue. If the lesions surrounding by fat, I suspect that to be surrounded by fat. If embedded within a fibroglandular tissue, I expect to see it in the other, because some rotations from modality to another modality occur, and you don't expect always to find. Yani if I have seen a lesion at 10 o'clock on mammography and I see it at 12 o'clock, or I have seen it as at 8 o'clock on ultrasound, I'll not get surprised. Yeah, it's expected. The lesion mobility between different techniques expected. Why? Because different positioning, different patient positioning between different modalities occurs. The patient on mammography will be standing, okay, upright. On ultrasound will be supine or oblique, lateral oblique, or lateral positions. On MRI will be in a prone position, and the breast is pendulous, is mobile. So expected the lesion to move some hours, okay, or some distance between one modality to the another modality. But we have some concept we have to consider it while we are evaluating. Okay, we have to consider the depths, we have to consider the internal structure, we have to put in our mind that we expect to find the lesion is moving between different modality. And sometimes as an alternative methods, sometimes to make sure they biopsy the same lesions was seen on mammography, they might add substance or put markers or after ultrasound biopsy, and then take a mammography image again to make sure they are the biopsy lesion is the same as mammographically detected one. So in these examples here, look for the lesions. More or less the morphology is irregular and size-wise, and these more or less comparable, and the surrounding fatty structures, okay, or fatty tissue, same on ultrasound. So we have to consider this. Generally, when I look for lesions on mammography and at ultrasound, if I have a CC view, I have seen it in a CC view, it will be much more easier because it will tell me in the medial or in the lateral breast. But generally, if I have seen a lesion only on MLO and I could not see it in the CC view, and usually on MLO is taken with some angle, and the angle is variable between 30 to 60. I'll not be sure, okay, at which area I have to search. In this case, sometimes, you know, they might do a lateral 90-degree lateral view, and looking for a lesion, and sometimes just doing ultrasound and expect the lesions to be moved in the same manner as the 90 degree. If a lesion's on the lateral, what do we expect to move? In which direction it will be moved in 90 degree mediolateral view? It will move up or it will move down? Do you remember?
Down.
Excellent. And the medial will move
up.
Okay. You remember muffin rise?
Rise and lead sync.
Let's sync. Okay. So you expect the lesions. You expect the lesions. Okay. On MLO, if it is lateral, and on MLO at upper outer, you might see 2 hours at lower level. Okay.
Okay.
And vice versa. If it is medial, it will be at a higher levels. Again, this is the fatty breast, and here this is a breast lesions. Okay, but good, we have a CC view. So the lesion, this one is central and this one is upper. Here both, this is central, so this is most likely at 9, and this one is a lateral, a little bit more lateral, and upper at about 10 o'clock. So this here, this is the 10 o'clock lesions, and this one is a 9 o'clock lesions. So if I could see it in the 2 view, it will be easier. But if I have seen it in 1 view, in a single view, it will be difficult. So, okay. So regarding the implant, what is the scanning technique for the implant? It is more or less the same. The patient, we have to optimize patient position the same as for the breast examination. However, and optimize the machines. However, we have to remember that we have double examination. We have two-fold examination. We have first to think about breast examination or examination of the breast tissue. We scan the breast as if there is no implant. We try to scan what we have seen from the breast tissue. Complete the whole study looking for the breast. Then go and scan for the implant. Don't look at implant apart and look at the breast. Look at it. No. Complete your study regarding the breast, then complete regarding, or the reverse. You can start by the implant, scan for the implant, okay, looking for its integrity and for any abnormality related or whatever, then, and its type and everything with information you can get it, and then go and scan for the breast. And this is here, this black image is implant, and this is a normal or a usual present radial fault, and this is a valve in a saline implant. These are silicone implant, and this is a saline implant, and here this is the implant down. Now we are scanning for the breast, and this what is the lesions, is a calcified fibroadenoma. Ultrasound, as you know, is the best modality for, or routinely used modality for interventional procedure of the breast. FNAC or core biopsy, cyst aspiration, sentinel node injection, localization of wire placement, guidance for placement of brachytherapy catheters, directional vacuum assisted biopsy, and so forth. Okay, why it is preferable over the stereotactic technique? Because really it is quick or faster, simple, less expensive, avoid radiations, portable, and real time control of the needle. Okay, but it needs skills. It needs skills and training for doing the interventions. It is important to consider the visualization, sharpen visualization of the needle, and to make sure the needle is not going oblique or perpendicular to the chest wall to avoid injury to the deep structure, especially the lung and the pleura. Try to make it or to introduce the needle, I mean, more horizontally, especially for the one with automatic fire. Okay, so it's going for longer distance, that is might hit the ribs, might hit the chest wall, or might hit the pleura. To avoid that, definitely Wafa is going to give you much more information in the lectures of the interventions. This is examples of breast biopsy, you see, for a complex lesions, and this is pre-fire here. Okay, the image guided pre-fire. This is the needle, and this is after firing for a vacuum assisted device, because the lesions, it was, as we mentioned, it is predominantly cystic. And look, the cyst is getting collapsed after the needle puncture the cyst, and the evaluation in this case was a fat necrosis. May I ask you about this? Which one is a good quality image? Both are invasive cancer. This one is invasive lobular breast cancer. Which one is a good image? Are optimized, more optimized image type? It's okay. Which one is more optimized image?
The bottom image is because it's labeled clock in a clock fashion.
Rihab, Abir.
Yes.
Oh, you are welcome.
السلام عليكم, مساء الخير.
عليكم السلام ورحمة الله. طيب, okay. I don't know what happened. Something wrong. Is it shared, the image? Have you seen it?
Yes.
Yes.
Yes, we can see it now.
Okay. So, this is one, yes, excellent, well done. Labeling, more labeling of the lower one. What else? Regarding the focal zone, regarding the grayscale, dynamic optimization, TGC, which one is more optimal?
The upper ones. The upper one.
Abir, did you attend? Did you attend that? Did you attend the
I
our
have
talk about? Huh?
I have joined about 1 hour ago. I
So
didn't attend all the lecture.
okay, so you are not going to comment on the optimization of the focal zone and the TGC. Rehab is there? Or she left? Are you there, Rehab? Okay, any of you who attend from the beginning. Regarding the focal zone and the grayscale optimizations or dynamic range optimizations, which one is more optimum?
Regarding the time gain, you mentioned that the fat, the subcutaneous fat, should be medium gray. So in the lower image, it's medium gray. In the upper image, it's
And that is why the lesion appear as cyst in the upper image.
Yes.
It's invasive cancer, but it appears as a cyst. But if you look, I will say the internal echoes being underlooked because it is high contrast image. It is black and white.
Yes.
Yeah? It is black and white.
Yes.
When we see very high contrast, only black and white, that means it is low time gain compensation.
Yes.
Low. That is why the contrast is high. But the lower one is gray. Is medium gray. The fat is medium gray. That is why the lesion here is hypoechoic with surrounding rim or thick rim of hyperechogenicity. So the lower one is more optimum, and even the focal zone.
The zone is more. Yes, it's more towards the lesion. While in the upper,
at the center.
Yes.
This one, yes, this is not at the center. It is a little bit at the upper part. Acceptable, but it's supposed to be at the middle or a little bit below. Okay?
Yes.
So this is the one. So to summarize what we have said. Appropriate technique is crucial to achieve accurate lesion characterizations. Difference in chosen parameters on ultrasound imaging can create variability in the appearance of breast lesion. Do you agree? Special knowledge of appropriate ultrasound techniques is essential for successful application of breast ultrasound. Ultrasound results depend on techniques employed on the experience of the examiner. This is the handheld ultrasound. We're talking about the handheld ultrasound, which is highly operator dependent. Okay, so select proper transducer frequency, adjust machine setting, maximize quality, should be optimized for breast ultrasound, and optimize the depth field of view. Sorry, I don't know what happened. Yes, these include optimize the breast ultrasound. We said include optimization of the depth or field of view and the grayscale or TGC or time gain compensation and overall gain. And in case of identifying lesions, we have to readjust accordingly unless we have a machine with auto optimizations. Okay. Optimize patient positions, flattens the breast against the chest wall, minimize breast thickness, will improve image quality and eliminate artifacts. The breast is examined in a different pattern to ensure that the whole organ is visualized. Accepted view, as we mentioned, long and trans, radial, anti-radial. A minimum of 2 scan planes is recommended in whole breast ultrasound. Radial and radial scanning planes are preferred over the minder scan, and we mentioned that because it improves the visualization of the lesion origin and its extent. And we mentioned that it's recommended to have at least single, in case of screening ultrasound, at least we have to have a single view for each quadrant and for subareolar regions. Knowledge of and understanding of current and emerging ultrasound technology, along with applications of meticulous scanning technique, is imperative for image optimization and diagnosis. Use all available technical facilities in the machine to improve resolution and optimize quality, including harmonic, color, spectral Doppler, elastography, speckles reductions, compounding, and so forth. Okay. If a potential mass is present in the tissue bundles, importance of transducer rotation in distinguishing pseudo-lesion from masses, and when a mass is identified and ultrasound setting is optimization, we have to scan perpendicular or orthogonal view at a 90 degree, and we have to sweep throughout to evaluate the margins and to visualize the lesion in a 3-dimensional pattern is essential to evaluate and characterize the lesions. And we have to consider palpations while scanning, and images of the lesions in a radial and radial view should be captured and annotated with right, left clock position, centimeter from the nipple. And this is definitely will make it reproducible for surgery, biopsy, and follow-up. Ultrasound guidance for biopsy is both safe and effective, and taking a biopsy of any lesion that is visible in ultrasound is technically possible. Oblique needle path carries the risk of injury to underlying muscles and pleura and the lung. Therefore, the needle path should be parallel to the chest wall to minimize deeper structures injury. Breast implants should be scanned with the same patient position. However, consider 2 fold examinations, one for the implant and the other for the breast tissue. And limitations of mobile and large or hugely large breast is considered, and post-injury, surgery, biopsy, or resultant in hematoma, all these can give a limitations for ultrasound and obscure underlying pathology. So it's important to have a careful review of prior ultrasound study will ensure accurate correlations, and the ability to synthesize breast ultrasound findings with multiple imaging modality and clinical information is also necessary to ensure breast patient care. And when searching for a lesion initially identified at mammography and MRI, as we mentioned, we have to consider the difference in patient positioning between the techniques, and we have to consider correlation with the depth and the adjacent anatomic structures. This is our patients. Look for this mammography here, dense breast, and the calcification barely seen, but well appreciated in this spot magnification view. When we have done ultrasound, look, it demonstrates segmental ductectasia, adding a lot of information to mammography, and soft tissue within the ducts, and demonstrating even we could appreciate the calcifications in a case of a DCIS with the good machines and good image optimization. And this is before 2010, long time before. In King Khalid Hospital, I had done it at that time, and it was proven to have extensive DCIS. And this is another patient, one of my patients. Look for good ultrasound machines, okay? And with good image optimizations. Look, if you have seen the image from front, you might say this might be a fibroadenoma. It is parallel and the anterior margin is so smooth. But by optimizing the image and looking for its deeper part, look the image here, the posterior part is burst and going and infiltrating not only pectoralis major but minor, but also pectoralis major. This is the pectoralis minor and major muscles, and the infiltrations by invasive cancer. If we could not see the deep portions of the lesions, we could not evaluate for the cancer even itself. At the end, we can say ultrasound is operator dependent, and meticulous attention to scanning technique as well as knowledge of various technical options available are imperative for an optimized and accurate breast ultrasound examination. And thank you. Any question?
Assalamu alaikum.
I hope you enjoyed. Alaikum assalam.
First, I want to thank you for this nice presentation. I have a question about the annotation.
Abir, you're welcome.
ترتيل عبد الهادي.
Tertil, ahlan. Are you resident, Tertil?
Yes.
You are welcome. At what level?
R2.
Wow, mashallah. You are welcome.
Thank you. Thank you. In the section of annotation, you said that we have 3 zones, zone 1, 2, and 3.
Yes.
The question is there any demarcation between these zones, or just it is suggestive?
No, there is no demarcation. Just it depends on the it is a small or large breast. In front of you, you can just divide the breast roughly into 3 parts. Okay, 3 equal parts from the periphery toward the nipple, and even the nipple area is not included.
Okay.
And the axillary tail, axillary tail is not included. Just imagine and divide the breast equally into 3 parts. The first part close to the nipple area is zone 1. The second part is the part far from the nipple at the periphery of the breast, circle throughout the breast. At the periphery of the breast is zone 3. And in between is zone 2. And just it is subjective.
Okay, thank you.
And even the depths, just you will imagine, okay, the lesion, if it is close to the transducer, is anterior, or if you have seen it in the anterior part of the parenchyma, this is anterior, or if it is close to the chest wall, is posterior. But if it is within the mammary zone in between, this is the middle. Okay.
Okay, thank you.
Okay, this depth is ABC, while the zone are 1, 2, 3. We'll talk the cross correlations later, inshallah, in details about the correlation between different modalities. We are going to talk about it in a separate lectures, okay, to make it more easier.
Okay, Dr. Bob, thank you. It's يعني ما شاء الله lecture. I enjoyed so much. Thank you very much. طيب I'm asking. لا سحر.
سحر. سحر عبدون.
أيوة.
Oh, you are welcome. I'm
Thank
so
you.
happy. I'm so happy to see you or to hear you till the end of the lecture and to hear from you questions.
Thank you, dear. Okay.
I'm so happy. So glad of that.
Okay, if I have a heavily calcified lesion, how to optimize the image to evaluate if there is an underlying mass or it's just a calcification?
Yeah, the calcification, you have heavily shadowing.
Yes.
So you want to eliminate the shadows.
Exactly.
Okay. I'll ask Hind, Suhair, or Medina. Are you there?
Yes.
Yes.
Okay. How we can eliminate artifacts, even including posterior enhancement and posterior shadowing?
Compound by compound implanting.
Excellent, well done. So spatial compounding, okay, is a technique eliminate all artifacts, even including the beneficial one, even including, okay, and improve both the lateral resolutions and contrast resolutions, and improve the margins and improve the posterior margins of the lesions, the spatial compounding. Okay, so if the machine, and I suspect you will have this type of machines in Dubai.
Okay.
Ask your the applicator, and you can search even in your machine. You might find one bottom regarding spatial compounding, usually used along with harmonics and speckle reductions. Okay, and these can eliminate the artifact. If you haven't, try to use low frequency probe and even convex. You can use a convex probe. Okay, I have shown you
elastography also.
Yes, elastography can give some help, but she would like to see the gray scale before going for elastography. So if you can use this just to eliminate.
Yes.
Yeah, yes, I told her the low frequency and even the convex one, the convex probe, convex transducer. It is deep. It will go deep, and you might see you might eliminate this artifact, and you will see deeper to this shadowing. Okay.
Okay.
يا بوس عاوز أسألك سؤال.
When some of you would like to ask, tell me who are you first.
I'm Sanabel, يا بوس.
Hello, Sanabel. You are welcome.
Thank you for the informative lecture. Actually, I had a problem with the dermal and subcutaneous lesions, the small lesions, and you said applying a thick layer of gel will
improve.
Yes, improve the visualization. Do you think about using automated ultrasound will improve the details of the dermal and subcutaneous lesions more, or will add nothing?
Really, you ask me question I don't know about it. First of all, I have no experience on automated ultrasound. Last time I presented for you from the literature.
Yes.
And this question, I don't know about it.
Okay.
While I'm studying it in the literature, nothing regarding this issue I had been faced with it.
Okay. Okay.
I don't know about it, but I will search. I can search and answer you later.
Okay, thank you, boss.
I did not practice it.
Okay.
I don't know if it can help in the dermal or not. I don't really.
Okay. Okay.
But inshallah, I will look at it, and if I find any answer, I'll let you know.
Thank you, boss.
أهلين دكتورة رباب.
أوه
أنا ولاء.
بروف you're welcome.
شكرا على المحاضرة الرائعة، استفدنا منها كثير. I have a question لكن ما عنده علاقة بالموضوع بتاع التكنيك. Last week I had a patient. She told me that she had a bulbable lump. When she showed it to me, it was just at the margin of the areola. And I think that was the transition between the duct area and the glandular tissue. Even on ultrasound scan, I didn't see any abnormality except a fat globule or something like that. When I turned the probe 90 degrees, there was nothing, just subcutaneous fat. Can I call it a fibrous ridge, or the fibrous ridge is the one with the distraction that you showed in the lecture?
You see, what are the commonest lesions related to the areola?
Ductal dilatation.
Okay, excellent. What else? Ductal dilatation, huh? What else? More superficial.
More superficial skin lesions.
Yes, skin related to the areola. What are the glands in the areola? These papules, you have seen it in the areola, getting large in the pregnant ladies.
The gland that secretes fat, but I can't remember the name.
Yes, yes. Who remember?
Montgomery nodule.
Montgomery
nodule. Montgomery nodules.
Montgomery's nodules. Excellent. Well done.
Tubercle.
Or tubercle. Tubercle, the one you have seen it in the projections or the elevations, you have seen it physically. But it is a gland, and common obstructions occurs, and when get obstructed, it get inflamed, not infected, not always infected, inflamed due to obstructions. And she can feel pain, she can feel tenderness, she can feel just a bulbable abnormality. So if any lady came to you, complain of bulbable, small bulbable nodule in the nipple area, okay, think about it. This is very common.
Okay, even if she was not lactating?
Generally, it increases in lactations. In any woman here, in any woman, but increase in lactations. In pregnancy, lactation getting large because this is its main job. But generally it is there. Yeah, it is present. So you might find it. But large amount whenever you scan the area, nipple areolar complex, use gel pad. Large amount of gel.
Okay.
Large amount. Then when you use it, you will use large amount of gel. Okay. You will make it as offset. You will increase it. You will put the skin and nipple areola and this area. You will put it in the narrower zone of the transducer, narrower field or elevation zone focus. So this is the narrowest part, the sharpest image. Okay, if there is any subtle findings, it will be more sharpened, it will give you more resolution. It will improve the lateral resolutions. Any blurring, it will disappear. And if there is any subtle, it will start to appear. Then you can adjust your machine, you can use harmonic, you can use Doppler, you can use other facilities in the machine to improve the visualization. But to visualize first, try to use a gel pad. Okay. And regarding the fibrous ridge, you can see it anywhere in the breast. What is the fibrous ridge? Yeah, you have seen now two examples of fibrous ridge. It can be sharp, يعني the parenchyma sharply tenting, or it can be humping, okay? Or it can be يعني focal area of fibrosis like this. The parenchyma is tented toward the skin, okay? And due to effect of fibrosis, it can pull the superficial layer or even the skin. But sometimes no need to pull. Sometimes you might find just a parenchymal ridge, not necessarily to be a fibrotic ridge. The parenchyma is amalgamated. Large amount of parenchyma is accumulated in a certain region, or it is humping, or it is tenting. Okay, and when it is tenting, because it is coming more anterior than the rest of the parenchyma. It is humping, and the rest of the parenchyma is parallel. So the fat lobule paralleling the parenchyma is coming from this side and this side. It will become soft, and the parenchyma in between, it becomes firm or hard. That is why it's getting bulbable. It becomes bulbable. Okay.
اوكي اهم حاجه فيها انها ما 3 dimensional يعني when I turn the probe 90 degrees.
No. It will
has
not,
no shape.
It is not a mass. It will not be 3-dimensional. So because it is not a mass. But if you could see a parenchyma like this coming anterior and with this criteria, that means you are dealing with a parenchymal or a fibrous ridge. But in the region of areola, again, think about Montgomery. Okay, think about Montgomery. Okay, thank you.
اوكي شكرا دكتورة، بعطيك العافية.
الله يعافيك.
المونتجومريز يا دكتورة رباب ممكن تكون solitary single one or mostly انهم يكونوا multiple ولا كده؟
Normally are multiple, but the one being blocked, it can be one or
isolated.
Usually solitary. Usually solitary, but it can be, and even one of the causes of the areolar abscess, or yes, the areolar abscess, one of the causes of the areolar abscess. When it's getting blocked and get infected, it can result in an abscess formation.
Okay.
Any questions or? Any more questions? Malaz, still, are you recording or you stop recording?
لا, I didn't. لكن خلاص I can stop recording الساعة.
Stop recording. يعني we can talk outside the lecture.
أي.
طيب عندكم